Hello everyone. I just finished my surgical oncology clinic and I wanted to sign in and address a question that I was asked today from one of my patients. So this particular patient is going to get a bilateral prophylactic mastectomy. And many of you may be familiar with that term, but for those who are not, a bilateral prophylactic mastectomy suggests bilateral, that is on both breasts. Prophylactic means in the absence of disease or for preventative purposes, and mastectomy is the removal of the breast. So this particular patient is in her early 30s and underwent genetic testing and found that she had a breast cancer gene that puts her at increased risk for breast cancer. And so she made an informed decision to have the bilateral mastectomy done. The question she asked for me is why, was it very difficult for her to be seen by healthcare providers to have this bilateral mastectomy done? And my answer to her is because many clinicians and even patients oftentimes need to inform themselves about when it's appropriate to have both breasts removed in the absence of disease. So there are three primary circumstances that data show will help lower the risk. And I say lower because in order to get benefit from removing both breasts to lower the risk has to be elevated. So number one, if you have a documented family, a documented genetic mutation. Again, this patient does have a genetic mutation. Many of you all may be familiar with BRCA1 BRCA or BRCA2. These are more commonly known breast cancer genes that show mutations, and it's data proven that they increase your risk for future breast malignancy. A second scenario is where you don't have a genetic mutation, but you have a very strong family history in either first-degree relatives or second-degree relatives in a premenopausal state. These are relatives that are that will usually have breast cancer, say in their 40s or 50s before they undergo menopause, and even male breast cancer. And then thirdly, if you have a histology that puts you at increased risk, such as atypical lobular, atypical ductal hyperplasia, these are markers of future malignancy, and these women we know are at, again, elevated risk. So the key thing is to know that your risk has to be elevated in order to get a clinical benefit from having both breasts removed. Now, nothing is 100%, but it definitely should be approached with a very measured and very thoughtful medical team. The genetic counselor should be involved, the surgeon should be involved, a medical oncologist, and sometimes a GYN or a patient's primary care doctor, but it's a multidisciplinary approach, meaning many clinicians get together and we discuss when it's appropriate and how best to go about managing the individual. Sometimes there can be other ways to lower the risk, like having the ovaries removed if you're done with family planning. This particular patient was not done with her family planning, so she elected to have a double mastectomy instead of having her ovaries removed. There's also medical ways in which to reduce your risk when the risk is elevated, and that's with tamoxifen. And of course, nothing is without side effects. There's always benefits versus risks, and so you have to speak to your clinician and temper that and see, will the medication be more harmful or more helpful? And if it's certainly more helpful, then it's definitely safe and advisable to proceed. I hope this information was helpful in terms of when to seek a healthcare professional regarding lowering your risk by getting a double mastectomy. It's something that should be well thought out, but I'm hoping that this information will at least give you a platform of things to consider before speaking with your primary care doctor, a breast surgeon, a geneticist, or a medical oncologist. Thank you.